Hey everyone, and welcome to this explainer for the Anesthesia Learners Academy. Today, we're diving headfirst into a massive tension right in the middle of the perioperative space. We're talking about the total collision between ubiquitous GLP-1 weight loss drugs and some very unexpected, life-threatening anesthesia complications. It's a huge topic, so let's jump right into the data and see what we're really dealing with.
Okay, let's get into this. Here is our roadmap for today's explainer. First, the GLP-1 tsunami. 2, pharmacology and gastric emptying. 3, evaluating the aspiration risk. 4, navigating the society guidelines. And finally, 5, clinical management and protocols.
Section 1. The GLP-1 tsunami. So think about it. What actually happens when the ultimate weight loss drug rolls into our OR? We're talking about medications that were originally designed just for diabetes management, right? But they've totally pivoted. They are a global phenomenon for obesity and weight management now. Patients are coming in looking great, feeling great, and honestly, a lot of times they don't even consider these injections as real medications, especially if they're picking them up from a medical spa or a compounding pharmacy.
Get a load of this number. 1 in 8 adults in the United States report using a GLP-1 agonist. 1 in 8. That is just a massive scale. When you extrapolate that out to the population presenting for elective or even emergent surgery, the odds are incredibly high that you're going to be administering anesthesia to someone with this active peptide floating around in their system on your very next shift.
Section 2, pharmacology and gastric emptying. Let's move to the pathophysiology and see how this builds. Looking at the heavy hitters in this drug class, check out those half-lives. We've got semaglutide, which you know as Ozempic and Wegovy, and that carries a half-life of roughly 1 week, dosed weekly. Then there's tirzepatide, or Mounjaro and Zepbound. That one has a half-life of about 5 days, also a weekly dose. And then we have the daily injectables like liraglutide, with a much shorter 13-hour half-life. But it's those long 5 to 7 day half-lives of the weekly injectables that are a really massive focal point for us, because getting them out of a patient's system, well, that just doesn't happen overnight.
And why do we care so much about the drugs still being in their system? 2 words: delayed gastric emptying. GLP-1 agonists fundamentally cause a massive traffic jam right in the digestive tract. I mean, that's literally one of the main ways they make patients feel full and lose weight. But in our world, in anesthesia, when you induce patient and pharmacologically knock out their protective airway reflexes, that traffic jam suddenly transforms into a severe, life-threatening pulmonary aspiration risk. This quote from Mass General's Dr. Ayaan Habbai absolutely hits the nail on the head. Lack of symptoms does not equal normal gastric emptying. Just because a patient tells you they feel totally fine, no nausea, no indigestion, that absolutely does not guarantee their stomach is empty after a standard 8-hour fast. The drug is just silently holding those contents right there in the stomach.
Section 3. Evaluating the aspiration risk.
This perfectly illustrates the classic Swiss cheese model of medical errors, specifically applied to pulmonary aspiration. We always have these multiple layers of defense, but when the holes line up, boom, a catastrophe happens. You've got the drug causing delayed gastric emptying. You pair that with standard and, frankly, potentially inadequate fasting times. Then you induce anesthesia, resulting in an unprotected airway and the total loss of normal protective reflexes. When all those things align, you've got a perfect recipe for devastating aspiration pneumonitis.
Which leads us to myth bust, a very, very common misconception: the 1-week withholding myth. Early on, the pragmatic advice floating around was simply to hold the drug for a week before surgery. Problem solved, right? Actually, no. Mathematically, because of that super long half-life, a patient who skips their 1 milligram dose of semaglutide is essentially just stepping down to a 0.5 milligram circulating dose. They still have heavily active medication right there in their system. Holding it for 1 week does not miraculously clear the stomach. But here's where the data gets kind of wild. A massive JAMA retrospective study looked at emergency surgeries, comparing GLP-1 users directly to non-users. The aspiration risk? It was statistically identical, 4.0% versus 3.9%. Now you might be wondering, if the stomach is full, why didn't the absolute risk spike? Well, the leading theory is that anesthesiologists are smart. In emergency surgeries, providers instinctively look at the patient and just utilize full stomach precautions right out of the gate. So the vigilant anesthesia technique is actually what's mitigating the risk there.
Section 4. Navigating the society guidelines. Now, what's really interesting about this next part is the shift in standard practice.
Because the literature is evolving so incredibly fast, we are seeing a stark contrast in the guidelines right now.
You have the standard ASA fasting guidelines that we've all grown up with, 6 to 8 hours for solid foods. But recently, a multi-society consensus aggressively stepped in and recommended a 24-hour clear liquid diet prior to surgery, specifically for high-risk patients on GLP-1 agonists. Think about that for a second. That is a massive operational shift from nothing after midnight to an entire day of clear liquids.
So the natural question is, who exactly qualifies as high risk under these new recommendations? Well, it's patients who are currently in the dose escalation phase, meaning their bodies just haven't adapted to the drug yet. It's patients reporting active GI symptoms, so your nausea, vomiting, or significant fullness. And it's also patients with underlying comorbidities that already delay gastric emptying, like long-standing diabetic gastroparesis. Recognizing these exact red flags in your pre-op assessment is literally the cornerstone of preventing a complication.
Section 5. Clinical Management and Protocols.
All right, based on all this data, here is a highly effective, actionable preoperative protocol. Step 1. Identify those high-risk factors early. If a patient is actively in the dose escalation phase, ideally you want to avoid scheduling elective surgery altogether until that dose stabilizes. Step 2. Adjust the fasting protocol. For those high-risk patients we just talked about, strongly consider that 24-hour clear liquid diet. Step 3. Utilize point-of-care ultrasound if there's any clinical uncertainty at all. And Step 4. When in doubt, perform a rapid sequence induction, or RSI.
Let's touch on point-of-care gastric ultrasound for just a second. This is an absolutely incredible diagnostic tool. It lets you place a probe right on the abdomen and visually verify in real time whether the stomach is full of solids, thick liquids, or if it's safely empty. But we have to be honest about the real-world limitations here. Not every anesthesiologist is trained to do this yet, and let's face it, in a high-turnover, super busy ambulatory surgical center, you may simply not have the time or the equipment available.
Which is exactly why rapid sequence induction, or RSI, remains our ultimate clinical defense. Huge institutions like the Cleveland Clinic have even adopted policies where they basically default to the assumption of a full stomach for any patient on these drugs. By utilizing RSI, placing an endotracheal tube with the cuff, and really minimizing the time that airway is unprotected, you safely bypass all the uncertainty of delayed gastric emptying altogether. Look, sometimes the safest airway is simply a rapidly secured one.
The landscape of weight loss pharmacology is evolving at breakneck speed, guys. But the core principle of anesthesia, that remains exactly the same. Fiercely protect the airway. So as we digest all this data, I want you to ask yourself, how are you going to adapt your practice for the very next GLP-1 patient who rolls into your OR? Stay curious, stay vigilant out there, and we'll see you in the next explainer.